Let's see here. All right, just before we get started, let's just go through the participants list here. There's a 347-203-8437 number. Whoever is 203-8437, can you just let us know who you are?
Hey, sorry, I was unmuted. Glenn Asada, FDNY.
Thanks, Glenn.
Don't let him in.
Oh, he's in already.
I agree.
Right.
Okay.
All right, it's now 5:10. Charlie, you have us streaming. Dave, if you're okay with it, I think we should get started. We'll do a roll call for, unfortunately, this is the painful part of a Zoom meeting, but we'll do a roll call for medical standards, followed by a roll call for Remack, which will be painful, but we'll bear with it.
Okay. Please respond when I call your name. Nicholas Alexandru,
Here.
Glenn Asada,
Here.
Paul Barbara,
Present.
Cindy Basilios, David Benelli,
Present.
Joseph Bove, Reed Caldwell, Wally Carter, Neil Semilovic, Robert Krupe.
Here,
I know I would.
I'm here.
I know,
Okay.
guys, I know
Lauren,
Marie is going quickly, but if you are not announcing yourself, the fact that you're in the participant list does not qualify for Remack. We need to actually say it, because that it has to be said on the live stream. So medical standards not as important as Remack. So if you're here and you're going to be called for Remack as well, for Remack, you must actually say that you are here, even though I can see all of you on the screen.
Lauren Kosturko. Dr. Kosturko says she would probably be late. Dario Gonzalez.
Here.
Doug Isaacs is not here, so Nick Cozy, who is his alternate.
Here.
Ed Jarvis. Bradley Kaufman.
Here.
Thank you. David Lobel.
I'm on the line.
Okay. Jeffrey Raybridge. Michael Redlener.
I'm here.
Great. Joseph Schenker. Anthony Shalish.
Yeah, I'm
I know
here.
Dr. Schenker's there.
I'm here. I just had to unmute myself.
Okay. Anthony Shalish. Rafael Torres. Excuse me. Thank you. Jason Zimmerman. Grace Casciola.
Here.
Madeline Fong.
Present.
Excuse me. It's not COVID. Anne Marie Gregenti.
Here.
Thank you. Sean Graves.
Sean Graves present.
Morty Lax.
Here.
Robert Ackerman.
Here.
Kevin Ward. Arthur Cooper.
Kevin's giving a test. He won't be here today.
Yeah, I
Yes.
figured he's very, very busy.
Yeah, Dr. Cooper is here.
Thank you. Eudidia Langstrom.
Present.
Lewis Marshall. Kevin Munjal. Was that Kevin? Jessica Van Voorhees. Okay, that was medical standards.
Hey, Marie, it's Reed Caldwell. I'm here. I'm sorry, my Zoom froze. I had to log back in.
Okay, no problem. I'm having trouble on my end tonight.
Marie, when we're going through the REMAC roll call, let's just pay attention to if we have a quorum.
Yes. Hey, this is Remack. Grace Casciola.
Here.
Grace, thank you.
Thank you.
Glennis Seda.
Here.
Bradley Kaufman.
Here.
Dario Gonzalez.
Here.
Nathan Reisman.
Here.
Pam Lai.
Here.
Nicholas Alexandru.
Here.
Nick Cozy.
Here.
Kevin Ward's not here. Anne Marie Gregenti. Anne Marie?
Here, Marie. I'm sorry.
No, it's okay. Samia McEachin or Alexson Burke. Jeffrey Raybridge.
Jeff, you on the
Reed
call?
Caldwell.
Here.
I'm sorry? Was that Reed Caldwell?
Yes, I'm here.
Okay, great. And Dr. Raybridge didn't answer, correct? Okay. Lewis Marshall. Michael Redlener.
I'm here.
Dominic Battinelli. Efren Rendon, Joseph Schenker,
I'm here.
Robert Ackerman,
Here.
Joseph Bove, Sean Graves,
Sean Graves, present.
Arthur Cooper. Arthur Cooper,
Yes, I'm here.
Robert Winchell. Dr. Winchell, Ed Jarvis, Mark Cantor,
Here.
Robert Krupe,
Here.
Timothy Stiles,
Here.
Laura Iacoli,
Laura's running a few minutes late. She'll join in a few minutes. She's in another
okay,
meeting.
is Dr. Kessler here? Wallace Carter or Matthew Fink?
Matthew Fink is here. Thank you.
Thank you, Dr. Fink. Eric Cohen? Kevin Munjal? Cindy Basilios? Matthew Harris? Jessica Van Voorhees? Benjamin Zabar?
Zabar here.
Okay, Paul Barbara?
Here.
David Benelli?
Present.
Dr.
I'm
Benelli?
here.
Thank you.
I'm here.
Peter
Thank you.
Wire?
Here.
Didier Langston?
Present.
Anthony Shalish? Okay, we have a quorum.
Right. Okay, thank you, everybody, for coming. It looks like Jeff just joined us. He put something in the chat. Jeff, if you're here, you just for the record, if you could just announce yourself.
Yes, hello, I'm here. Thank you.
Oh, thank you.
I'd
Hey,
like to try.
And this is Kevin Manjal.
Oh,
I joined late as well. Sorry.
Perfect. Thanks, Kevin. All right, I'd like to try to do it a little different than what we did in the past. I'd like to follow the REMAC agenda. And during the medical standards subcommittee report, we'll do all the medical standards stuff. This way we can stay a little bit more organized and hopefully get out of here a little bit quicker. So that said, can if anybody's reviewed it, can we get a motion to approve the September 9th meeting minutes? Or if anybody has any changes or questions about those minutes, please speak now. All right, hearing none, is there a motion to approve them?
Motion to approve.
Thank you.
Second.
Thank you. Okay, the correspondence report, Marie?
Okay. Just give me 1 second to pull it up. It's pretty short. The correspondence report for October 21st, membership, Dr. Bodick has had to vacate the psychiatric physician seat. He is recommending Dr. Adwa Smalls Mante who also applied at the same time that she did. She was also a fellow at Columbia, and she's interested to join the REMAC. So that will be going to our membership committee unless you want to appoint her tonight. Fire Department EMS, no new information. From the New York State Department of Health, the following enforcements. Christopher Howland, $2,000 penalty, Amsterdam, New York. And from Brooklyn, New York, Christine Correa, also a $2,000 civil penalty. No new information from our ambulance agencies. We sent out agendas, minutes, and associated attachments for this meeting. And the protocols were sent to CMAC for review. Those are the HAZTAC and rescue medic protocols. And we sent out an advisory with the updated protocols.
I believe
And
those
that's the end of
protocols went to
correspondence.
the committee yesterday or on Tuesday,
Yes, they were approved.
and they were approved at CMAC.
CMAC and SEMSCO, yep.
So that can go into the training cycle. I know that fire had a need to get them into this year's training cycle, so that can happen. Okay. Any questions about the correspondence? As far as the new physician, I believe that we can vote to approve, but then it would need to go to REMSCO in order
Yes.
to have that person be a voting member. Any questions regarding that doctor's not here? Is he, she?
No, she is not here tonight. But we did not invite her to be here tonight.
I think we should reach out and find out if she's actually interested, because
No,
to have
she is.
somebody-
She reached out to me. She emailed me. She is very interested in taking the spot.
Do you have her
But if you'd like
resume?
to-
Do you have her resume?
Yes. Everything was previously when she applied, and we selected Dr. Bodick instead of her. So we have all her information. She's also a Columbia person.
And what spot is that? Is that the at-large spot or a specific spot?
Psychiatric emergency physician.
Pediatric emergency. Okay, gotcha. Thanks.
Psychiatric.
Psychiatric.
There you go.
Yeah. I mean, there's certainly no rush. If you'd like, I could send out her resume again to everyone on the committee, and you could vote at the next meeting, whatever you decide.
I believe that Pesach has his hand up.
Sure, go ahead. Pesach?
Hi, I just have a question about the protocols that were sent out in the advisory. It was a draft copy, and it did not include the GOP or the appendices. Is there a final version that will be released?
Yeah, I posted everything on the website. We'll be sending out the advisory again with the page showing the specific changes with all the protocols. So I'll be sending out an update of that probably tomorrow.
Excellent, thank you.
Yeah.
Okay. Any other questions about this? So I would suggest, being that doctor is not on right now, if we could get her resume sent out to everybody, and then any comments, and we'll vote at the next meeting.
Okay.
Okay, Tim, you raised your hand.
Yeah, thanks. I don't have the agenda up in front of me. I just wanted to make sure, Marie, that you still had it on your plan for trying to also send out Dr. Foot's resume as we need to replace Dr. Quinn as me for primary, if possible, for DOHMH, and Dr. Foot as a secondary representative.
Yeah, I apologize. That was actually discussed at the last meeting, and I thought that we had approved that, but I will double check. If not, we'll bring it forward.
Thank you.
Okay, thank you, Tim. All right. Anything else with correspondence, Marie?
No.
Great. The executive committee did not meet since our last meeting. I will move to subcommittee reports. I'm going to go a little bit out of order just because medical standards tends to have the most, and I want to give everybody else a chance to speak. So we will go CNC, followed by QA/QI, followed by training, and then we'll do medical standards and do it in that direction. So Dr. Barbara, CNC?
All right, thank you. CNC met on October 13th remotely. Our push for this legislative year is to upgrade the exam content to mirror the 2022 protocols. And we have this quarter up until December to launch an exam that's in congruency with the new protocol launch in 2022. The last year or so, it was tough with the protocol changes, but now that we have a little bit of greater stability in the protocols, we're aiming for a new exam with revisions to mirror the existing protocols on the street at the same time. I'm confident this will be completed due to the hard work that other people will do to write questions. And me. The physician exam is being rewritten using small groups to have a 2022 cohesiveness via the protocols. And so the existing exam is at times not in current protocol, or not relevant to the medicine. So a small rewrite's going on with that, and about a quarter that's done. And I've met with some people on the call individually. I'm happy to have more small groups, but if you're a physician who does medical control and you want to have some input in what the test tests, we have the next 3 months to launch a new exam.
Also, very importantly, the input that Paul is talking about is now, before the exam goes to print and is out in circulation. Because a lot of times people will come back after the exam and say, why is this a question? Why is that a question? If anybody is interested in working on this exam, please reach out to Paul. He is dying for the help. So please, thank you. Go ahead, Paul.
Also, what I'm being able to learn from the paramedics and the liaisons is we're actually judging what content the test tests. And there's a lot of esoteric medical decision-making questions that are irrelevant to current OLMC practice. And I've been able to get input from people who practice OLMC routinely. So we're actually going to have a breakdown of what the test is. And I'd like to come back to this group at some point and ask what the ideal breakdown is with regards to GOP appendices and protocols. But we'll get there. Let me get the content first, and we'll fine tune that later. With regards to the exam itself, the analysis that we typically do is going to be put off until 6 months of the new exam. So we'll probably have exam analysis come the next REMAC cycle, because if it launches in January, we need to get a good amount of test takers to study it. Other than that, there's really nothing else going on with CNC. Mr. Ward has asked, though, that he has a unified list of all paramedics in the region. And if you're offering CME, he asks that you send it to him and he can distribute to everyone. Mr. Lax is also aware of this. And, between people in our region, the publication of available CME really should not be at the behest of a couple of megabytes of data in an email. So please email Kevin. I'll put his email in the chat. So if you have a CME, please, so he can get it to people so they can get to you. That concludes the CNC report. Any questions?
Joe and Paul, I'm sorry. Can I just add something?
Bring it. Yeah, please.
Yeah, I'm sorry. It's Glenn Fader from the fire department. I'm sorry to take this time up, but if any of the all my medical control physicians are interested at FDNY, we were advised that the city hiring freeze is lifted a bit. So we do have some positions open. I'm sorry to take the time to say that, but if so, please reach out to us and we'll get you the online link. Thank you.
Oh, that's great. We need people practicing OLMC.
Great. Any other questions? Paul, anything else?
Negative, Ghost Rider.
Excellent. Thank you for that report. Next, we're going to go to the QA/QI committee. Dr. Redlener. I know I saw him here somewhere.
Hi, good evening, everyone. So the quality committee did not meet between the last REMAC and this. We had to reschedule our meeting for next month. And, just a reminder that we will be, again, hoping to bring to the REMAC meeting next month our updates related to our quality improvement project around stroke and STEMI. And we'll hope to show you an updated dashboard with the First Watch program. For those of you who are not engaged in the First Pass or First Watch, the expectation will be that you send your data to the committee itself. Yeah, that's it. That's the report. Thank you.
Great. Thank you very much. Any questions for Dr. Redlener? None. I will move on to training and education. Mr. Lax.
Hi, so Training and Ed last met on October 15th, last Friday. Will be another meeting tomorrow, and the committee has been broken up into smaller groups that are meeting intermittently to finalize the protocol training. We're adding an extra focus on the areas that pertain to what QA is working on lately, specifically stroke, STEMI, some of the issues that were identified there that have been reported here in the past. The state will be hosting it on Vital Signs Academy, just like they did the last time. John McMillan confirmed that for me, and he is going to assist us in packaging it and posting it.
Great, thank you. Any questions for Morty? Okay, great. Marie, going forward, if we can add under training and education, another subcommittee or tag report, which is going to be the Ecmo Tag. I'll let Dr. Benelli talk about that during the medical standards report, or during the medical standards meeting, I should say. So for now, we're going to switch over to medical standards, and then we'll come back and do the interfacility and keep going that way. David, all you.
Yeah, hi. So interfacility, I believe Dr. Berkowitz emailed us that he won't be able to attend tonight. So I don't know if we will actually have.
We're going to push that report to next.
Yeah, that's fine.
Next month.
Okay, so let's start with the medical standard portion. So the correspondence report we already went through, CNC we already went through, protocol. Do we actually have to motion to approve minutes for medical standards, Marie, or is that engulfed in REMAC?
It's one set of minutes. Marie's on mute, but it's one set of minutes, Dave, because they're joint meetings, and statutorily only the REMAC meetings need to be officially approved.
Perfect. Okay. So let's move to the protocol committee report. I don't believe we're bringing anything for a vote tonight, but Dr. Lai, why don't you present what we did?
Yeah, sure. So the protocol committee met on October 8th. There are no protocols to be brought to REMAC for tonight. I think that we discussed this a little bit, just that it just might pose a little bit of a confusion just in terms of our protocols that we approved in June will be coming out in January of 2022. So we're hoping that I think that with our remaining protocol meetings for the rest of the year, that we should probably have just very few minor changes to be brought to REMAC, and those I think that for to ease any sort of potential confusion, we're hoping that we will just bring those to the January REMAC meeting. We did have discussions though, however, in terms of slightly modifying some of the language in the current protocols, including the definition for discretionary orders that we will be bringing forth sometime in the near future, as well as the pediatric severe bradycardia protocol will also have some slight modifications. For our next, we did have a discussion in terms of having, discussing the need to have a severely agitated patient protocol that may mirror some of the language that is in the current state collaborative protocols. We do have some members that are going to be working on that, and that I think that will be a main topic of discussion for our next protocol meeting. Our next protocol meeting is going to be next Friday, October 29th at 10 a.m., just as a virtual Zoom link.
Okay, thank you, Dr. Lai. At the tail of the protocol meeting and just as connecting to what was discussed in the correspondence report, I'd like to thank everyone. We'd like to thank everyone who was at CMAC, Doctors Marshall, Alexandru, Raybridge, who else? Cooper, Langston, who helped us pass the rescue and hashtag protocols through CMAC and REMSCO. Thank you very much. Okay, so moving forward, let's talk about the Ecmo Tag. I'll present it, but everyone who's on the Ecmo Tag, please feel free to join. And so unfortunately, our Ecmo Tag did not meet this month due to some scheduling issue with the Zoom meetings. So we did not meet, and we're going to meet next month. We'll have to schedule a date. But what we did want to do after communication with email, we wanted to update with the progress of where we stand thus far. So thus far, as we have mentioned previously, we have decided to start a pilot in Manhattan that would involve bringing cardiac arrest patients with very select criteria, and we'll go through that in a minute, to hospitals that can initiate ECMO in the hospital. And that would involve identifying these patients, putting them on a Lucas device or equivalent, and then bring them to hospitals that have agreed to participate in this pilot. So far, the hospitals who have expressed interest in Manhattan and have ECMO programs are Bellevue, Mount Sinai, and NYU. And again, they're not committed to join the pilot yet, but they have expressed interest in joining it and hearing further. We had a hard time communicating with, reaching out and initiating a discussion with NYU, with NYP, New York Presbyterian, both Cornell and Columbia. But thankfully, I've had a phone call last week and some email exchanges yesterday with both Columbia and Cornell. So hopefully we'll be able to move this forward and get them on board as well, because we do want to have more than 3 hospitals participating in this pilot. So what I do want to show today and present today, and I'll share my screen in a minute, is the suggested pre-hospital portion of the protocol that our tag has worked on developing over the past few months. And I think that before we put up the protocol and go through it quickly, it is important to notice that this is a draft protocol and will remain in a draft status, because we have not shared this protocol yet with anyone outside of the group, and it's definite that once we share this with the participating pilot hospitals, they will have their comments, and obviously they're very smart about ECMO, and we will modify our protocol accordingly. The way we built this protocol, and Paul, Michael, Pam, anyone who's on the tag, please feel free to join. Niall, if you're here. We reviewed Mark Cantor. If we read Caldwell, everyone who's on the tag. We reviewed the literature. As you know, there are quite a number of publications already that talk about pre-hospital ECMO, about bringing cardiac arrest patients to ECMO centers. And some of them are very favorable, some of them are less favorable, and our goal is probably to try to mirror and get the favorable results. In some studies, it's up to 43% discharge home with good neurological outcomes, so that's not insignificant. And we looked at the indications and contraindications for all for these patients, and we tried to synthesize them into our protocol to have similar inclusion and exclusion criteria. And that's how this protocol is built. So let me pull up the protocol now. If I'll share my screen, let me see how I do that. Just 1 second. Share content, screen. I'm gonna start the broadcast. Okay, you should be seeing my screen, and I'm gonna try to pull up the protocol. Here we are. So as you see, there's a big draft at the bottom in the middle of the page, and it will remain that way because it will change. And we'll simply just go through this quickly. So Remack in New York City, Remack of New York City will start a pilot where cardiac arrest patients who meet the below criteria will be expeditiously transferred to hospital, can initiate ECMO, life support, and continue ECMO care. Because it is understood that these patients might have to remain on ECMO for quite some time before you can determine whether there's improvement or not. The pilot applies to patients 18 and older and will be initially performed in a limited geographical area of New York City. And it will also be, I should add, it will also be limited in time, perhaps only 6 months, just to see that, just to show that we're able to do this. Okay, and the format is, thanks to Dr. Barber, the format is very similar to our regular protocol. So CFR and all providers follow the CFR section in the current New York City Remack non-traumatic cardiac arrest protocol. EMTs is essentially the same. For paramedics, and here it becomes, here we go into the details. Excuse me. Continue paramedic section in the current non-traumatic cardiac arrest protocol. And then the EMS supervisor who will arrive on scene, the FDNY EMS supervisor who has the Lucas device in the back of their truck, he will assess the patient for inclusion and exclusion criteria. The inclusion criteria, so it's ages 18 to 75 with a presenting rhythm of VF or VFib or VTAC with at least 3 defibrillation attempts made. And that includes AED use prior to paramedic arrival, or PEA if the arrest was witnessed by bystanders and CPR was ongoing until EMS arrival. So that's regarding
Dave.
Okay, go ahead, Paul.
Yeah, it came up on the screen. Why don't we pause here for questions? Because then the protocol gets a little bulky after that.
Okay, anything so far?
The only thing I would say is you have on-scene EMS supervisor assessing for pilot inclusion and exclusion. This protocol would apply to non-911 units who don't have a supervisor but have a Lucas and have the same ability to take these patients. I don't know if EMS supervisor, or how do we do that?
I don't think that we should. I think that we should probably at this point, since we keep this at FDNY and not,
you can't do that. This is not an FDNY pilot. This is a REMAC pilot. Other agencies will be able to participate as long as they meet the QA component. So we cannot limit it to one agency in our system unless it's an agency pilot, but that's not what this is. This is a regional pilot. So we just have to figure out a different method of who is assessing for inclusion and exclusion.
Joe, so there was no intention for this to come off as an agency only pilot, and I think
I know, and I don't.
You bring up a good point.
I'm just saying I think it's everything I see here is correct, except that I think we have to just broaden this EMS supervisor to include other, meaning maybe lead the goal. Person, I don't know how you call it.
The goal is to avoid the paramedic who has to do all this other work being, overwhelmed. And the idea was that on all 911 arrests, a supervisor should be part of the situation. Perhaps we should just I'm okay with ad hoc, just removing that on-scene supervisor and just write member of EMS team,
Well, I am not okay with that. I'm sorry.
I don't know what that means.
Because, I don't know what that means, and I don't know. And I think that
you're not okay with that language. You mean?
Yeah, I don't. I don't know. I think that it has to be someone who is separate and has a supervisory role that will be able to assess and the person who and decide whether to communicate this. So this is really, I suggest that we take this discussion offline at the moment and just go through the protocol and bring this as a point for discussion at the Ecmo Tag. Because I think that I think that
a lot of the people that are on this call are not at the Ecmo Tag calls, and they might have.
Okay, so then the Ecmo Tag, that is fine. So the Ecmo Tag will discuss this and come up with a language or with a solution that would be that would be appropriate for everyone. You are on the Ecmo Tag, Joe, so, and you did
No,
receive
I'm
the
not saying
protocol report.
me. I'm not saying
Yeah,
me.
so-
I'm saying that there are other people.
Okay, so I suggest that we take this offline, and then I note your comment, and that we take this back to the Ecmo Tag and find a way to mechanize this in a way that will meet the regional pilot.
Let's keep going though, because there may be other points.
Okay, very good. So the next part of this is transport considerations, and that would be 30 minutes or less transport time to nearest ECLS pilot hospital, and that kind of sort of falls in line with prior studies that we looked at. You have to be at a place where you can initiate ECMO within 30 minutes transport, which which probably would be okay for most of New York City and definitely for Manhattan. Now we go into the exclusion criteria. So the exclusion criteria, that again, this is based on numerous studies that were all synthesized in here, all put in here. So severe illness, so a patient obviously with valid DNR, directives, including but not limited to what we accept, which is most, and New York State out of hospital DNR. But I think we would not limit it only to that. If the patient has advanced directives, a healthcare proxy says that the patient wished not to be resuscitated, then that would probably, we would accept that. That's section 1. Section 2, terminal illness or comfort measures only hospice care patients for known severe illness, including but not limited to oncological conditions, cardiac, respiratory, neurological, kidney or liver diseases. All these we would exclude out of the pilot. The second section of the exclusion criteria are the arrest dynamics, so traumatic or hemorrhagic etiology of arrest, and that would be asystole during 2 or more rhythm checks, and persistent end-tidal CO2 of less than 10 after we implemented all ALS measures and interventions. So any discussion on this section?
Question.
Okay,
So
yes, sure.
This all makes sense. I'm just curious. I don't know how much clarification this needs, if any. It looks like the only true exclusion in terms of arrest dynamics when it comes to rhythm changes is that asystole popping in during 2 or more of the rhythm checks. Is that during transport? When there are certain changes during transport, what's the expectation? Especially in a prolonged transport, let's say 20 to 25 minutes.
Well, we're not, well, hopefully the transports will be much shorter than that. And that's an excellent question that I don't have the exact answer to. Maybe if Niall is on board, is on tonight, he can add. I would imagine that this decision is made up to transport. The minute we start transporting, we're gonna make the notification and we're gonna, through telemetry and bring the patient to the hospital. The hospital will always be the one that's gonna decide in the end whether they're gonna initiate ECMO or not. And I guess if we do have asystole during transport, we must inform that to the hospital and allow them again to decide whether they still want to initiate ECMO or not. The bottom line,
David, I would agree with, I would 100% agree with what you said. I think once the decision has been initiated to bring the patient to an ECMO site, then they should continue on in spite of what they find en route, and then the hospital team will make a decision.
Yeah, I think that would be the only way to handle it, because we can't, in the end, and we tell that to all the hospitals that we discuss with. In the end, the people who are going to decide whether we're bringing the horse to the water. The hospital is going to decide whether they're going to initiate the ECMO or not. We're just enabling the option. That's what we can do in the pre-hospital setting, and the decision still is and will always remain that of the hospital.
Dave, if I can just say something for a second.
Sure.
That's the same principle as when we have STEMI and they go back into cardiac arrest, and we've already made a decision to go to the STEMI center. It's the STEMI center that makes the final decision regardless.
Very good.
And
good point.
David, just 1 second. There's also a key part of this is, training the crews on this extraordinary new lift. And if we stop the patient en route and just have like a false start, there's going to be cases we bring in that don't get ECMO. And just like any other launch, there's going to be a learning curve. And so I would advise that this is about as wide as the net of screening as we can get. That's reasonable. But a lot of these cases are going to be, in order to get that really good case, we're going to need people very competent on it on a routine basis. So stopping en route for exclusion criteria is not the design of the protocol.
I agree.
And Dave, one other point,
yes,
if I
sir.
may. Up on your exclusions on severe illness under the do not resuscitate directives and most forms, I think you should limit it to that, only because that follows state statute. Anything else that you put in there would not be acceptable as far as a DNR by state statute. So
true. And then we thought about that and we had a discussion about that and we did decide to leave it a little more broad. And I completely understand your reasoning and appreciate it. But if we bring a patient that has an advanced directive or healthcare proxy that says, no, we don't want to resuscitate this patient. We didn't want this patient to be resuscitated. Please don't start him on ECMO. Then it's futile.
But that's the hospital making that decision. That's not us.
I know, but we will. I don't think that it makes sense to bring a patient where the healthcare proxy says the patient does not want to be resuscitated and does not want to be put on ECMO, to alert the whole Ecmo team and everyone to bring them down to a patient that does not want that intervention. That's why we left it a little broader.
And just remember, Nick, this patient is going to get standard of care cardiac arrest treatment.
Thank you.
Right?
Yes.
You're still getting.
I was just about to say
everything that we would normally do to resuscitate them. But I think that when we're making a decision to include them in the pilot project, I think that I think it's okay to be a little bit less.
But you're kind of making that decision against possibly the patient's wishes. They don't know if this is the case or not.
Nick, what I would say is, I was going to make the point Michael just made, that standard of care cardiac arrest is different than being a good ECMO candidate, and I don't think that broadening this is really going against the patient's wishes. I think it's goes to what's the appropriate treatment. Is the patient appropriate for this pilot or not?
Well, why wouldn't we let the hospital make that decision if the patient fulfills the criteria?
Because the hospital, it's a huge effort to initiate ECMO, and to and the minute we give a notification, please prepare your ECMO team to start this. It's a lot of people involved. It's a cannulation team, it's the ECMO team, it's the ER team. And if they are not gonna,
in all honesty, they've made this decision already, right? Like, I don't know if you talk to the ECMO teams, they will tell you that they exclude all these patients with advanced directives.
But that's the hospital making that decision. I don't know if we should be making that decision.
That's correct, and we should not. But this is why we're working in conjunction with the hospital, and we can leave this open. And if the hospitals, when we present to them this protocol, if the hospitals will say, "Hey, we want you just to limit it to most and to New York State out of hospital DNR," I'm okay with that. I'm definitely okay. Fine. That's a point for discussion.
I can go either way, but perhaps maybe we should get some legal advice on this as well, because it is a statute.
Hold on.
No, I don't think so.
Nick, guys.
Bring it all back to the tag.
Hold on. Guys, stop for a second. Nick is correct that the statute says out of hospital DNR and a most, we do not honor a living will in the pre-hospital setting, or we're not supposed to. That has to be a decision with medical control. We can put that as an exclusion criteria for ECMO, however, right? We can say that for somebody who has a living will, they will be excluded from our study or our pilot. That we can do, and that is okay. We're not saying that we're not following meaning we can't not start resuscitation on a patient who has a living will without talking to a doctor, but we can say that if you have a living will, we are not going to include you in, we might start compressions, but not include you in the ECMO pilot. So that we can do. So I think that's okay. They're two different things. One is limiting our pilot population, and one is what we're legally allowed to do. So Nick, you are right, and David, I agree with what you put here. This makes sense. I do think there are
I'm sorry.
There's two people with their hands up.
Okay, just 1 second. I'll just add again. We are just as Joe said, we are providing the standard of care. And how many times when we are in telemetry, and all of us know this, that people call say, "Oh yeah, he doesn't have an most, he doesn't have an out of hospital DNR, but he has a living will," and we many times honor it. So there's no reason. Okay, go ahead. I don't see the hands raised.
So I have it. Mark Cantor, you had a question.
Just one point that's worth mentioning is we took these exclusion criteria directly from basically every study that's out there on this. And we actually left it purposefully broader than even most of them did, expecting, I think, that the hospitals will ask us to narrow it anyway. But I agree with the points that you just made otherwise.
Okay, and then Ben Zabar.
Yeah, I was just going to say, in lots of studies or demonstration projects, you have a more limited population, and you're excluding people who it could potentially maybe be beneficial to, but it hasn't been proven to be beneficial, so they're not really disservice because they're still getting the standard of care. At some point in the future, it may be brought in, but there's lots of studies where kids or pregnant people or whatever are excluded. So I don't think someone who is a MOLST and they're not being taken to an ECMO center, and they may still go to the ECMO center anyway, because it may be the closest hospital. I don't think they're really being, discriminated against. I think it's fine.
Agree. Okay.
Okay, so let's move on then. Any other discussion on the comment on the, if not, let's move on. So for patients meeting all of the inclusion and none of the exclusion criteria, the EMS supervisor, or whatever term we'll choose for this, will A, contact OLMC for transport approval to the nearest ECLS pilot hospital, place the patient on a mechanical compression device, and instruct the EMS provider to prepare a patient for immediate transport. And now we go to the medical control options. Again, since we might be bypassing, similar to LVO, similar to STEMI, since we might be bypassing closer hospitals, it will be, we'll have to contact online medical control, and online medical control will determine patients' eligibility for direct transport into the ECMO pilot hospital, and online medical control will provide a notification for the receiving ECMO hospitals. And then on the bottom, we just have a couple of key points, considerations, which just to clarify, so ECMO pilot hospitals that have a temporary inability to provide ECMO care must immediately advise FDNY OLMC in order to avoid the potential that will bring 2 ECMO patients to a hospital that can only handle 1 ECMO patient. The ECMO pilot hospital must provide the New York City Remack with patient outcomes with QA/QI. If not, they cannot participate in our pilot. So far, all 3 hospitals agreed to that. It is understood that there is a limited number of hospitals with resources required to initiate ECLS and continue ECMO care. It is absolutely understood. And, when we do, this is just a pilot for now. When we implement this citywide, we will have to decide with the larger hospital systems how we're going to implement this in places that we may not have shorter transport times. But that is something to review and discuss in the future. Any further questions or discussions now?
To think about at the tag, you right here, FDNY OLMC. Is FDNY OLMC then going to contact all of the OLMC centers to let them know this list? Or is the anticipation that any agency would call FDNY OLMC for this pilot?
Oh, that was my question.
Okay, that's an excellent question, and I would answer the same way we do it for LVOs now. Should apply for this pilot as well.
Okay.
And I don't know exactly how we do this for now, so that's something that we have to check. Nick, maybe do you know what happens when Nick Alexandru?
You're muted, Nick.
I don't know. Can you just re-ask that question? I'm sorry.
Yeah, sure. So Joe asked what happens when what happens when we when an LVO center or an Ecmo center needs to go offline because either their machine is broken down or they already have an Ecmo patient.
Right.
Who notifies the other online medical controls that a facility is down?
Well,
Who's responsible for that? The hospitals or us?
The hospitals call FDOC and FDOC calls us and they let us know. I don't know if FDOC is calling other telemetries. I know our telemetry does not, that I know of. So that's interesting. But the
that's something to look into.
It's listen, something for the tag to work through, whether we'll have all agencies call FDNY OMC, or we'll have to have a method so that other online medical control agencies get the information that's needed.
Because right now the stroke LVO goes through FDNY. So,
well, no, that's not true. But they go to their medical control facility. They might not have the most up-to-date information, but it goes through their regular online medical control facilities.
But not the 911, not the 911 LVOs.
This is not a 911 project.
Right. I'm only saying because you asked that question. That's why I'm saying
right.
That. Yeah.
Okay, Rob Ackerman, you have your hand up.
Sure. I have two comments or suggestions. One with the conversation about the supervisor or designated supervisor from the other agency. If we can checklist this out so somebody's not relying on memorizing the protocol or reading this protocol when they're on scene, if they can have a checklist made that they could use on scene, I think that would be very helpful.
Sounds like a training and education piece.
So that's something I wanted to know.
Yeah, Morty, you just got spanked there.
No, I think that this is something that we were talking about as well. The tag will also work on creating educational material and operationalizing this. So part of that would be, training and education, etc., and that would be addressed. Absolutely.
Sure. And number two, again, from a provider standpoint for the buy-in, as we were talking about, if there's a way to give provider feedback of the outcome. I know at our agency, for instance, when we do an interfacility STEMI, the providers really like hearing how the patient did themselves. So if it's possible to actually give the providers who treated and transported the patient the final outcome.
That's a broader question. Maybe I think that's a QA/QI thing. that's a question for QA/QI.
All right, Mike Redlener, welcome to the party.
It's like great delegation going on here tonight.
Yeah,
that's right.
Anyway, listen, I think, David, I think this is a great start. I think that there's obviously a few little pieces, but I think it's good for everybody to see what's coming down and be able to look at it. I see that Paul has his hand raised, and then I'd like to, if there's no more questions, move on. Paul.
So I think you brought up a good point about the medical control piece, Joe, but I think that question goes beyond this protocol. And I would look to the REMAC executive leadership or, this body to identify situations like this where more than one medical control may provide direction and, agency centric coordination. Maybe there's multiple risks and benefits to a single central agency that does all the medical control in the region, or multiple agencies who require real-time communication. So I don't know what that perfect solution is, but that problem is beyond this protocol alone.
Sure, that is a very good point. Mike Redlener, you have your hand up.
Yeah, so one thing that I would suggest, and again, David and I have kind of talked about this offline a little bit, but I think it's time to start socializing the initial plans and bringing these plans to our colleagues in different hospitals. I don't know how the committee feels about that at this point, or do we want to resolve all of the issues? I just worry that the further we get down, the kind of the more catch up that our partners will have to do.
No, I think that's a great point. I think that at this point we have the beginnings of a protocol. Obviously, we need buy-in from our partners and hospitals to make sure that everybody's on the same page. With a pilot, it's a relatively small group, but I do think we need to bring them to the table now and see how do we map, meaning these patients that are on the fence, do they want them to come to them, or are they patients that they're not going to take no matter what? I mean, we will have to hold them a little bit accountable for the percentage of the time that they do take a patient and put them on ECMO, because if we find through this pilot that, we're bringing X amount of patients and only 1 or 2% are put on into an ECMO program or into an ECMO treatment, then that tells us a lot going forward about how to approach this. So I do think we have to bring in the hospitals now, and then between the Ecmo Tag and meetings with the hospitals, bring this back when it's a little bit more polished to Remack.
Very good. So I think that we have a little more work to do on the protocol itself, and then hopefully we'll get by then on board. We'll also get New York Presbyterian, and the next step would be to start meeting with them. And we've been talking about a couple of options, and Michael Redliner, we might be able to do this. Paul, I'm not reading your text messages. I'm sorry. We might be able to.
It's more to Joe. No, I think it's more. It was a formal suggestion that we actually poll the non-FDNY OLMC facilities to see if they even want to have this decision. They may not. Maybe they do. I don't know. Before we go rewriting everything
I think that if an OLMC facility is providing services to an agency, that agency is going to reach out to their online medical control facility.
Absolutely.
Unless, as a rule, we say to call FDNY, which has to be willing to take the volume.
In a pilot, absolutely. In a pilot, it's a geographic pilot, though, Joe.
I think that this is more of a discussion for the Ecmo Tag. I think that we see the protocol. I think that this should move to the tag for further discussion.
Yeah, I agree, and I agree with Paul's point as well. And I think that in the pilot, when we're talking about small numbers, we might decide to keep it tight, but we'll see. Let's talk about this in the Ecmo Tag. I don't think we need to waste everyone's time here. So that's the report of the Ecmo Tag. And as I was saying, we might try to bring Greater New York Hospital Association on board also for this, for meeting with the hospitals. But we'll see. I'm trying to think if there's anything else for the medical standards meeting. I do not believe so. As the interfacility tag is not, there's no one, John Berkowitz is not here. So that ends the report of medical standards.
Great, thank you very much. RTAC, is there anybody who is reporting from RTAC? Okay, hearing none, we'll move on to the Regional Council update. Dr. Langsam.
Okay, give me a second. Here we go. So Marie sent me a whole bunch of stuff here. Let me just go through it. REMSCO met September 23rd, 2021. Following is a summary. New York State DOH statement, EMT Basic may administer COVID-19 vaccines, but they clarified yesterday, but not the flu. Medics, on the other hand, can give both COVID-19 and the flu. There was a series of New York State DOH enforcements, which you already read. I won't go through it again. There was an email to DOH requesting clarification of vaccination mandates. Okay. And for the non-hospital based EMS providers, and I believe they told us that at the present time, they can't force non-hospital based EMS providers to be vaccinated. There was a very interesting discussion about this yesterday at the Remack, followed by the REMSCO, and perhaps Dr. Krupe will comment on that. Let's see what else is over here that's of any importance. The ambulance committee is going to continue to discuss whether ambulance security stickers are still needed. New York State DOH released a mobilization request for September 2021 through 2022 to provide ALS units throughout the state and 7 sites in the metropolitan area. New York State DOH was asked for details about the activation, but the state has not responded. All BLS, this is important. We have several BLS first response agencies in New York City. Most of them have DOH approval because they've received agency numbers. There's one or two that do not have DOH approval, but we have recognized them. We have now informed them that 60 days from the day they get the letter, REMSCO will no longer support their operation unless New York State DOH approves them, and we will so notify New York State DOH. Teaching and education, training education is developing a protocol update that was spoken about already. A moment of silence was held for Rebecca Solomon, a paramedic from Maimonides Medical Center who died from suicide, which highlighted the importance of mental health. And Dr. Krupe will head a joint REMAC and REMSCO tag to explore beneficial mental health to help our EMS providers. This is separate from the mental health a project that Marie and REMSCO are working on. And the next meeting of the Regional Council will be held October 26th via Zoom.
Hey,
That concludes
any
my report.
questions for Dr. Langsam? I know that this, the new vaccine mandate and all the things that are coming out, I know have a lot of people on edge, but I don't know that we're going to have all the answers tonight.
Hey, Joe.
Yes.
It's Matt. How are you?
Hey.
So just, you can tell me if you want to put this off to new business, but just food for thought that there are several other large bodies in the state, including the EMSC Advisory Council, who are writing to the Commissioner of Health in favor in support of a mandate for all EMS providers, regardless of their affiliation, whether it's volunteer-based, paid, hospital, et cetera. Obviously this group broadly represents a lot of different agency types, but I think it's something we should consider.
Consider what specifically, Matt?
I think I would make a recommendation that we write a letter as the REMAC to the Commissioner of Health in support of a statewide mandate for EMS providers.
Is that a motion that you're making?
I'd like to make a motion to do so. Yes.
Okay. Do we have a second for that motion?
Before you make a second, I think we should have the discussion of some of the things that went on at the CMAC, because although a similar motion was first introduced, there was then a lot of second thoughts about whether making a motion like this and then either having it fail or not, for some reason not pass, would send out a significant message. Plus the fact that throughout the state there was, although I'm sure all the physicians were for such a mandate, many of them, and these are talking about physicians, were concerned about the political fallout of losing hundreds of their EMS providers and crashing the entire system. I know that that throughout the state there is a crisis in EMS. In fact, a very lengthy statement was read. I mean, Dr. Krupe should be doing this, but since you brought this up, I'm afraid that if we stop this discussion now, we may be going down a path that's very dangerous to us, unless you want to take the risk. But
I was going to say that perhaps the timing of this motion is out of order, and maybe we should have the CMAC REMSCO report first and then come back to this.
That might be a good idea.
Sure thing. Thank you, Jeff.
Okay. All right, so let's do the CMAC REMSCO. I'm going to let Jeff do the CMAC, and then Bob, where are you? I don't see you right now, but you'll do the REMSCO. So Dr. Ravitch.
Thank you. So CMAC met on Tuesday of this week. As you heard earlier, the New York City protocols were presented and approved. As we discussed earlier, there was some questions, but they were well addressed by Dr. Lai and others, and it passed without much issue. There was, as Dr. Langsam has alluded to, there was a rather lengthy discussion at the CMAC. I would say, at least a 45.
You froze.
Make a recommendation.
There we go.
Jeff, we lost you at 45.
Jeff, you might want to turn off your video because I think you're just freezing.
Yeah, sorry. Is that better?
Now we're good.
Yeah. So there was a very lengthy discussion, and as Dr. Langston had alluded to earlier, yes, the EMSC presented that they had room.
Not frozen again.
Not in support of the mandate itself, but in support of encouraging the vaccine. And then the discussion got into, do we say we support the mandate? Do we say that we encourage it? You know, there was a lot of commentary about how decimated EMS around the state is already, and concerns about this leading to further loss of personnel throughout the state. And ultimately, it did come to a vote at the CMAC, which was a tied vote, and actually it did not pass. The motion did not pass to send a letter to the commissioner. So, you know, just keep that in mind as we have that discussion later about our own motion, that there were a lot of concerns on both sides of that argument. Those were kind of the major topics. There was a discussion of the Muru app as well, and there were concerns expressed by the physicians, mostly around the cost to the provider or to the agencies with Muru for some of the features. It was noted that the initial startup costs from the state for Muru actually came from an EMSC grant. And the biggest concern was that the dosing calculator is behind a paywall with the app, and that you have to pay for that. And the concern being that there was you know, we're most concerned about accurate dosing, particularly in our pediatric patients, and that why would this not be available, you know, free of charge. So the Bureau's position was that, you know, this is an app that they've kind of gone with to make available, but that it's not an exclusive app, and that any other app could be used, or people are free to make their own decision, was how the director phrased it. And I know we've had previous discussions about Muru here, but those were the concerns that were expressed. Those were the major action items. With one additional item, there was discussion, and it was voted by the CMAC to support, and the SEMSCO voted to support as well, which is a letter to the commissioner requesting that the position of New York State EMS medical director be established, and that position report directly to the commissioner to allow for EMS physician input directly to the commissioner's office, given some of the challenges we have had during COVID with emergency protocols and other recommendations reaching the commissioner and being acted on in a timely fashion. Yeah, I know there were others here who were at CMAC. That's my recollection of the major issues. I don't know if anyone has anything to add.
Yeah, Jeff, if I can add one thing to that, just because it affects everybody, the region and everybody else, is that as opposed to the executive order, Ryan made it very clear that they're not extending the EMT certification any further, even though it kind of says it on there. But Ryan was very clear to say that it doesn't fall under the need right now for the state to execute that. So even though it says it in the order, they will not be extending the EMT certification any further.
Yes, it's a very good point. He made it clear that it was as needed at the discretion, really, of the Bureau. And you're right, they are not extending it currently. I think that's it, Joe. Thanks.
Okay, thank you so much. Marie, actually, Art Cooper's had his hand up for a while, and then Marie. Art, go ahead.
Thank you, Joe. I just wanted to clarify remarks that have been made about what took place at the EMSC meeting, so we're very clear about that. After extensive discussion, the EMSC Advisory Committee made a motion which was unanimously carried to send a letter to the commissioner asking that he or she, it's he now, but it'll be she after December 1st, we presume, make a strong recommendation that pre-hospital personnel be vaccinated against COVID. That recommendation was based on not only the available science in terms of the efficacy of the vaccine, but also the fact that that pediatric patients are among the most vulnerable groups out there because they themselves have not yet been vaccinated. We know that the adolescent age range has just begun to be vaccinated, but the 5 to 11-year-olds are not expected to follow suit until the data becomes more widely available later this year. So again, and we all know that children are, much more likely to develop asymptomatic cases, and that they are therefore, very likely to be transmitting the virus to their families and to their schoolmates. It was on that basis that the EMSC Advisory Committee made the recommendation that all pre-hospital providers should be vaccinated. Again, it was the request of the commissioner was to make that a strong recommendation, not a mandate, for the very reasons that you heard Dr. Langsam, iterate earlier in this call, namely that it had the possibility, there was the possibility that a true mandate could decimate the services upstate. I will say no more about this at this time. I simply wanted to clarify what EMSC did. If anybody has any questions for me about the EMSC position, I'll be happy to answer them at this time. Thank you.
Thank you. Marie. We can't hear you, Marie. You're not muted, but your microphone might be off.
Okay, can you hear me now?
Yes.
Okay, I was double muted. This is scary. I just wanted to ask if this committee would think it's a good idea to send a letter of support for the statewide EMS medical director, which I think is a step in the right direction to make sure that our physicians and EMS community have a real voice when it comes to EMS, and so we don't have to wait 3 weeks during a disaster if we need to do something emergent and have a physician-to-physician conversation. I can't make the motion, but I'd like someone to consider it.
I'll make that motion.
Is there a second?
Second, Braybridge.
Are we also including nominations?
You interested in the job?
No, but Paul jumped to that
the
one.
The motion on the table is to write a letter of support for a statewide medical director to the commissioner's office from the Remack. Any discussion on that motion? Anyone? Hearing anybody?
Can we stipulate the salary?
I don't know that it's a salaried position, but it's a good question. We should put that in the motion.
This is a
I'm
rare.
sure it won't be great. It's the state.
It might be helpful to know who are the nominees, then we can decide whether to support this or not.
There are no nominees right now. This is a motion just to get this job in place. I'm sure you'll all have an opportunity to put your names up.
I'm sorry, Jeff, you were saying something?
Yeah, I was saying that it's really, the motion is just, in the letter from CMAC and SEMSO commissioners to establish the position. There are no nominees currently. There's no salary. It doesn't exist yet.
And I also
Jeff,
want
are
to
they
add
asking?
that I think this is a letter coming from CMAC and the state. That I don't know that individually the regions really need to do that. I think it's covered by the state.
Well, I think that as a region that has been seeing the state trying to cede more and more authority here, I think that as a region, we should say something, and we should be clear that, we, in the state of New York, we have the largest population of EMS board certified medical directors. So we should have a say, and we should be at that table when they're making that decision. So
Well, Joe,
I do think it's important to come from us.
Joe, on that note, in such a letter, would we make recommendations for job qualifications to that extent? Being board eligible, board certified. I mean, there's obviously
the first step is to support the idea of an EMS medical director. The second step, once that position is approved, I do think we need to be very involved on every level in what we believe an EMS medical director should be, what their credentials should be. But I think step one is to support the process if we believe in that.
Yeah, Joe, that question came up actually at the SEMSCO. And pretty much the response of most people there was that, if the commissioner agreed to create the position, that, the CMAC and SEMSCO and, the REMACs through the CMAC would offer their opinion as to qualifications and design of the position.
And that makes sense. Dr.
Clearly,
Barber,
we
I see
need
his
someone
hand-
from.
Hold on.
Clearly, we
Paul
need
has
someone
his
from
hand
New York
up, and
City.
then Dave.
Sorry.
I think this is a rare opportunity for us to align with the other regions that are sometimes bickering for the same scraps off the table. And ultimately, not having a positive voice in this will be a tremendous deficit. And it could actually, our absence of support on this could actually stop the process because of the size of our region. So I can't agree with Joe more on this. We absolutely we should support it. And we should have input on it. But all of those other concepts are premature. The first piece is getting the position named.
All right, David?
No, I'm good. I just wanted to add to the qualifications that he has to be on New York City REMAC.
I mean, I think we should let's crawl before we start running or walking or whatever we do. Okay. I think that we've had a significant amount of discussion. As our parliamentarian, do we need to have a roll call vote for this, or can we just ask for nays?
That came up at the SEMSCO CMAC, believe it or not, and the answer is no, you do not need a roll call vote for this.
Excellent. So is anybody opposed to writing this letter? If you are, please speak now. If not, we will go ahead and write a letter of support.
Seda, opposed.
Okay, thanks, Glenn. Anyone else?
Thank you.
Okay. Thank you, everybody. All right. So that is the regional council. Bob Krupe, are you still here? I don't see you. I don't know if you wanted to add anything for SEMSCO. Okay, seeing no Dr. Krupe.
I think that was pretty much I mean, since I'm the alternate, I was there. I think that's pretty much the discussion that went on.
Okay.
There wasn't much else. This was the big issue that dragged along. There was a big plea. Apparently, they're going into a major discussion about EMS in crisis. I shared along with Marie, I just sent it to her. Maybe she wants to even send it out about the problems with EMS across the state. And actually, someone came up with the idea that maybe EMS doesn't belong with the Department of Health, with the Bureau of EMS, and maybe it belongs somewhere else in the state, implying that the state is screwing it up, which might be partially true. So this is a big deal coming up. I don't know where this is going to go in the future, but certainly this is something big. The other thing is, I caught during the Remack meeting, and correct me if I'm wrong, if our director didn't make a sort of off-the-cuff remark about when New York City is going to get its protocols up to date with the state, that we will see sort of addressed it to what's his name, from to our chair of not you, Joe, back to, oh my brain is fried, the chair of the Medical Standards Committee,
Marshall Benelli.
Yeah, Dr. Marshall. Yes. I heard like a 30-second remark from him about nosebleeds and stuff. When are you going to get your protocols up to date? I don't think they've dropped.
Again, I have the utmost respect for Dr. Marshall. I think that I've said this offline many times, and I'm going to say it online now. I don't think that he is representing what the physicians at this meeting are saying at the state level.
It wasn't him.
I have a big problem with that.
You misunderstood me. It wasn't him.
But the director.
No. It was Ryan.
No.
Ryan made
Ryan
the
also. I don't think he represents what we say. I don't think he represents what anybody says. But that's a separate issue, and I'll say that for the record too.
Okay.
But yes, we definitely need to be represented by the voice of our region. Okay. Anything else on this issue? Okay, hearing none, We will move to unfinished business. I'd like to ask Dr. Kaufman if he can give us a report on the behavioral health program that the fire department is doing with the mayor's office, I believe. Brad, are you okay? There you go.
Hi, how you doing? I think I was muted. I put together, there's a few slides if I can share.
Sure. Charlie, can you give him the ability to share, please?
If not, it's not critical.
Hey, you're all set.
Okay, can you all see the slide?
Yes.
So this is what we're calling the Be Heard program. I don't know if we've officially given the name before at the Remack, the Behavioral Health Emergency Assistance Response Division. And this was, I guess we presented here at the Remack on January 5th, and it was supported. This is the letter from Dr. Schenker supporting the program. There was a 5-week training program that started in April. After that, the program included a number of different training modules, including a lot more deeper dive into behavioral health issues and situational awareness and handling crises directly on the scene. These were some of the topics that were included in that training. This is just a picture of the map of the area. So it's 3 different police precincts in Upper Manhattan where this Be Heard units are currently operating. So I just wanted to show you to get to, they're being dispatched to an EDPM call for Mental Health Response Unit, EDPM. And these calls are being screened by the emergency medical dispatch, and they're asking these questions to make sure that it's a safe situation. So these are, I put the flow chart on the right, but I know you can't see that. These are some of the questions that are being asked to determine when it's appropriate to make an EDPM call. Because for those calls, if it's within that zone and a unit's available, the police will not be responding, and just one of the mental health response units, the Be Heard units, will be responding. So is the patient doing anything right now to harm him or herself or someone else? Are you in immediate danger? Is the patient violent? Does the patient have any weapons? Are you calling from a mental health facility? And this was the units, how they rolled out. So it's a non-transport vehicle, as you can see there, with MHR on the side for mental health response. There in the vehicle are 2 EMTs and a social worker from Health and Hospitals. There are 2 units that are within the zone for 2 tours a day from 9 a.m. until 1 p.m. From 9 a.m. until 1 a.m., 16 hours. These 2 units will be operating, or have been operating. And here's some of the initial data, just a kind of an overview quickly. They've been responding to about 80% of the calls, of the EDPM calls. The other 20%, they're not available. Sometimes it's on a border, Atom, or for some other reason. And then if you compare the ones they go to versus the traditional ambulance response, there's actually a lower RMA rate because we think they're better connecting, taking the time, and the social workers are heavily involved in that connection. And this shows where these patients are ultimately transported to. So if you recall, there's another option. There's a support and connection center up in the area where they can transport the patient to. And you can see that where one of the goals is to decrease unnecessary transports to the emergency department. And in the first month of this, where we're looking at this data, it has been shown to be decreasing the emergency department transports. And by the way, I'm happy to share all this data with anybody who wants. So just briefly, some of the next steps, the plan is to expand the pilot to a larger area in northern Manhattan as well as into the South Bronx. So that's just an update that we want to provide. Nathan, I don't know if you had any other Nathans, obviously, from the medical directors as well. Any additional?
Yeah, we'll probably expand in Harlem itself by the end of the year. Actually, the mayor's office or Thrive NYC's planning, they announced that about an hour ago. We're going to expand just to a couple more precincts, and then probably expand further depending on how that goes.
Great. If there's any questions, we'd be glad to answer, or we will continue to provide updates in the future.
Can I ask a question? So sounds great. It sounds very successful. So congratulations on that. And I hope to see it roll out, further. Just curious if there's outcome data a little bit beyond, it may be too soon for that, a little bit beyond what's going on now. Do these patients end up in crisis? Do they end up in hospitals later? I don't know if that information is even compiled yet. It might be too soon.
Yeah, that's a great question. And actually, currently that's not information that we're actually collecting. So it's not being looked at, but it's definitely an idea that I will suggest if there's a way of doing that, following up, the future visits of these patients.
Yeah.
Okay.
I'm sorry. I'll just take one more. I also see Chief Cacciola, who's obviously a key member of this whole project. Chief, anything else you want to mention?
No, we just continue to compile metrics so we can place the information on the New York City Thrive website. So if anyone wants to view the New York City Thrive website, they are going to be supplying reports, I believe, monthly.
Great. Thank you very much for that. It seems like it's a worthwhile project. I think that, finding out how many of these people call 911 a second time would be also very valuable to see if there's repeat callers out of this group. Okay, that concludes our unfinished business. Under new business, Dr. Seda, did you want to bring something up?
Yes, thank you. Thank you for the time. Thank you everyone for all your assistance with everything. As you know, Mayor de Blasio announced yesterday that all city employees, including fire, police, EMS, must be vaccinated by 5 p.m. October 29th, or they will be placed on unpaid leave. And ultimately, I guess after 30 days, they are terminated. We have at the moment about 59 to 60% of our members, EMS or fire, vaccinated. So that leaves about 40%. I think with this mandate, easily 20, hopefully 20, 25, maybe even 30% will go ahead and end up getting the vaccine before October 29th. Ultimately, maybe about 5% of our workforce. Now, I know it's only city employees, so just FDNY members. I know all the voluntary participants have your own vaccine requirements, whether you're tested or whatnot, but the city has gone with either vaccinate or terminate, I guess. So we just wanted to bring that to your attention, although it's nothing new, I'm sure. But we are trying to come up with contingency plans depending on what ultimately our numbers are. Chief Cacciola is on the line for any operational issues. For details she can bring up, but a lot of things are internal on our end, such as making all tours in the field for FDNY ambulances 12 hours, canceling vacations, raising the cap off or eliminating the cap off of overtime and things like that. Things are internal. Some of the things on the outside, we probably may have to request mutual aid from REMSCO Remack resources. I know those are BLS units, but we may need to get that out there. Our first deputy commissioner asked about the NAC ambulances, but that's not going to be possible. We already know that. At the federal level, all those ambulances that came to help us, during our peak, 250 ambulances or so, really greatly helped us out. But those ambulances are elsewhere with COVID directly related issues, and they're just not available. So we know that that's not going to be an option. So we're trying to figure this out. A lot of it's going to be internal, as I mentioned. Potentially the other thing too, and I spoke to Joe Schenker the other day, the idea of a single medic unit to spread out crew members. Joe told me that actually potentially is still in play. I know we have union issues and things like that, but from the operations perspective, I'm sure that they may be reaching out to the voluntaries as we used to do in the summers for enhancement units to see if you can assist in putting out more units. But I just want to bring that back on everybody's radar, although I'm sure it is already on your radar within your agencies as well. But we are trying to figure out what the heck to do, as that deadline is just a week away from tomorrow now. So just wanted to see if you had any things to bring up, or if Grace had any more details you want to provide, or, we're kind of trying to figure this out as we go. So thank you for your time.
Thank you. So we have Yadidja has his hand up, and then Marie has her hand up. So Yadidja.
I just have a question. When you reach out for mutual aid, will you be requiring the people who provide you mutual aid all to be vaccinated as well? It would be paradoxical if you say no and your own people have to be vaccinated, but I'm not sure all the volunteers are vaccinated, which is what the state was talking about. And I know some volunteers are, for whatever crazy reason, refuse to be vaccinated. So that's an issue.
Yeah, I think that's a great question, and yeah, it would not make sense that we can't use our own employees because they're not vaccinated. But the mutual aid piece of it is not ours, FDNY or the city. But I don't know if they would. I would have a feeling that maybe the mayor's office would say that anybody participating, even assisting, would have to be vaccinated. That would make sense. The unions are trying to fight this, but as we saw with the teachers unions and such, and things going to court, it was not, the mandation was upheld. The fire side also is saying that they feel that firehouses will be closing. I think that was what one of the union reps said earlier today. So, our CFR responses are part of EMS as well, our third-tiered system. So we are looking at what kind of response we can continue with that as well. We may even have to look at potentially closest units, depending on what our numbers are. A lot of things that we're trying to figure out that we may need to pull the trigger on.
Great. Marie?
Glenn, I read in the newspaper that the mayor has given Department of Corrections until December 1st because they are some sort of discrete, smaller group. So maybe the Remack can write to the mayor's office and make a suggestion that EMS should also be to wait until December 1st.
Yeah, that's very interesting, because the reason that the mayor has said the corrections would be delayed till December 1st is because they're short-staffed. So I think we're going to end up in that same situation. So it's kind of ironic, right?
And also, I think the Remack might be able to write, to give an idea of the number of deaths that may be attributed to a lack of EMS may be far beyond anything that could be attributable to COVID. But I don't know if we have numbers for that.
I might play devil's advocate on that.
Hold on 1 second, Mike, 1 second. Ben Zabar had his hand up, and then you'll be next.
Yeah, I just want to bring up today at the press conference, the mayor was directly asked about basically that, about shortages of firefighters and EMTs, and the risk that poses, and was not very receptive. And that was sort of brought up about the corrections officers. So I don't know. I'm just not sure how effective a letter from the Remack is sort of bringing that up is going to be, because it seems like they sort of feel like, shortly before the deadline, a lot of people are going to get vaccinated and it's going to work out. I mean, clearly, like Glenn said, we're playing for if that's not true, but I don't know how receptive City Hall is to a letter.
And yeah, interestingly, the mayor did say that, oh no, for EMS fire, that he has a contingency plan. So we're waiting for him to share that with us, I guess.
That's good. All right, Mike.
He has a contingency plan. Okay.
Listen, Listen, I think that all of the health systems went through this same issue. And honestly, I think it's important to force the issue for all of us who are taking care of vulnerable people. I think that sooner, I know that there's going to be staffing issues or a fear of it, but I don't think that we should support postponing a mandate.
I'm sorry. I hear that, and I hear that, and I get it. And we've been trying to track the staffing issues at our ED, and I got to tell you that as much as we're saying that, there's one hospital now for 3.5 days that has requested total diversion. And so we can't grant that, obviously. So as much as we're saying, maybe we shouldn't do this and that, this is a problem that's only getting worse because, Greater New York has been giving us numbers about hospitals. There are about 5 hospitals that have potential problems. And this one in particular, I don't want to name any names, but 3 days now requesting total diversion. We can't function. Now just imagine that starting to multiply. We got to do something. We'll run it. Our response times are still going to be prolonged. We'll get there every fall. And, like in any disaster in the past, those storms and such, by the time we get there, the patient is ceased, gone, whatever the situation is. Mm-hmm. We'll do the best we can with it because we have to. We don't have a choice. We're 911.
Yeah. Listen, I think it's a very polarizing issue right now. I don't think as a region, this mandate right now does not affect the entire region. I don't know that we as a regional body should be in writing a letter of support and then not saying that our other sectors should be vaccinated or not or whatever it might be. I don't know. I don't have a strong opinion either way, but I think that we are in the middle of two things here, and I think that one of the things that we really have to lean towards is policies that we've put in place. We've already said that a paramedic unit can operate with a single paramedic. That obviously is not something that the union wants to hear, but we know that that's a possibility and that might stretch our resources. And we know that most of the hospitals have been through this where they've had to get everybody vaccinated and make decisions. I kind of agree with Mike that I don't think that we should, as a body, be putting anything out right now. But I think that there's definitely things that we can do. I think that operationally, FDNY probably should lean on the 911 voluntary hospital contracts and ask for more resources if possible. They probably have the same, shortages that you do. But I think that there's enough pieces of the puzzle in place right now that we have to kind of see where things are going. But more ideas that people have, if you could bring it to myself or to Marie, we would be more than happy to share it with Glenn and with anybody else to try to help mitigate this as best as we can. Okay, any other pieces? No problem. Thanks, Glenn. Any other pieces of new business? Hearing none, it's 6:50. I think that's pretty good. We got both meetings done in an hour and 50 minutes. So I thank you all very much, and hopefully we can get to in person sooner rather than later. Have a great rest of the night, everyone.
You as well. Stay safe.
Take care.
Joe. See you.
Bye-bye.
See everybody later.
Bye-bye.
Take care, everybody.
Have a good night, all.
Bye.